right, Patrick. I need some history from you. What happened today?
Today, I just got up, took some toast, and came to the hospital.
Okay. Why did you come to the hospital? What was it that caused you to feel like you needed to get evaluated?
Just a really bad chest pain. Just all of a sudden happened. I couldn't. I had to hunch over to walk. Lessened when I sat down. Couldn't lay down on my back to that side.
Is that right? What were you doing when it started?
Driving my truck.
So just driving your truck, and all of a sudden you had the sudden onset of chest pain.
Yeah.
Do you smoke?
Nope.
Good, good. So you don't smoke. You're fairly tall. You're a fairly tall guy, and you're fairly thin. So those are people who tend to have these pneumothoraces. And do you feel real short of breath?
Not right now.
On your chest X-ray, you do have a very large collapsed lung, so a large pneumothorax. Your collapsed lung's very small because it's collapsed. What do you do for a living now? Are you students?
I got a Augusta Tech.
Okay, all right. So Adrian, what are you giving as far as pain medications?
So just pre-medicating for anxiolysis with 1 milligram of Ativan IV and also with 25 of fentanyl IV. We're going to hold an additional 25 of fentanyl for further analgesia as if needed for the procedure.
Okay. Patrick, you have no medical problems of any kind?
No, sir.
Okay.
Just to kind of walk through the procedure, it's going to be second intercostal space, mid-clavicular line, where we'll be introducing our needle and our incision will be made ultimately. So I'm just feeling for my landmarks at this point.
So you're using the true closed system?
We're using the Uracil, which is the true closed system. It's a chest tube that actually fits onto the chest as an apparatus and doesn't require the atrium, can be just hooked up to low intermittent suction directly to our wall suction.
So he can get up and actually walk around after he's had this place.
That's correct. And for a stable pneumothorax, this is the ideal, meaning a patient who has no respiratory distress or profoundly hypoxic crashing. This is the procedure of choice.
You get all clean, let me put this away.
So why is it, in your opinion, the procedure of choice?
It's just for comfort, and this will essentially, looking at him right now, he's in no profound respiratory distress. The Uracil will not reinflate his lung immediately. It'll occur over time, and that's okay because it's not as if we need him to. This can improve over shorter periods of time, and that's adequate.
Right.
All right, we'll leave you flat, okay, bud?
Okay. So is the drugs while I'm starting to feel something?
Yeah, so you should feel kind of
Happy?
high, I suppose.
He's afraid he's going to get some pain. So what would have happened if he hadn't come in?
That's a very good question. Mom, do you mind being on YouTube?
No, I don't mind.
Okay. So this is Mrs. Lillis. Yeah, he would have been at risk of potentially getting a tension pneumothorax, where as the air builds up inside the chest cavity, it actually can cause pressure on the vascular system, and people can get hypotension, a drop in blood pressure. They can go into basically shock, and they can die from it. So a tension pneumothorax is an extremely worrisome, concerning emergency, and he's got a huge pneumothorax, and he would have been at risk of a tension pneumothorax, in my opinion, based on what I see there, because that lung is actually quite collapsed there. That's the concern about these pneumothoraxes. All right, good question. So Adrian, what I'd like you to do is just each step of the way,
Sure.
give us pointers and explain what you're doing.
Okay. So first things first, we just prep the area. Well, first we've shaved the area just to allow adhesive a little bit of a better seal. Then we prep the area with core prep 3 times. We're allowing the core prep to dry at this point because we are introducing this is a sterile procedure. We are introducing a catheter into a sterile cavity.
I'll squeeze it in tighter.
No, I can hand it off to you.
Oh, okay. I thought
just
you
wanted
wanted
to
to
make
leave
sure-
it. Okay, I
make sure
got
we
you.
had something
Okay,
that
no
fit.
problem.
Okay, so everything is prepared. So our suction is prepared. The patient is prepped currently. We're not going to anesthetize the area. Alright, so currently the patient is prepped and we're just feeling for landmarks at this point. We have the clavicle and first rib, and then we're moving down into the second intercostal space right here. And that's where we'll be introducing our needle and our trocar. You doing okay there, my friend?
Yeah.
Alright, sir. Just relax. The first thing that we're going to do now that we've identified our landmarks is to anesthetize the area with just a wheel. Alright, bud. You're doing awesome. And that's just a wheel, okay? And then with a 22 gauge needle, we'll go through our wheel. Into the thoracic cavity, anesthetizing as we go down. And essentially what we're looking for at this point, when we begin to aspirate, which is not right now, will be air. Alright, so we got
I
air.
see some air bubbles coming back up.
Those are your air bubbles, and we know we're in the thoracic cavity.
Okay. So how
So I'm going to just continue to anesthetize that area. We'll just make a note of where.
so that needle that you had was 1.5?
That's correct. Just going to extend that, make a little incision with our scalpel just to allow for the apparatus to be introduced. And it's a simple matter of pushing directly down. A little bit of force. And then it's connected.
Patrick, you doing all right? Can you pull that paper back just a little bit?
You got it? Alright, and then
Squeeze as hard as you want.
we remove our trocar and close the urocell.
Doing all right, Patrick?
Yes, sir.
Okay. Tell us if you're feeling bad.
And that is essentially it. We got low intermittent suction on, Renee?
I got to continue to
No, that's fine.
Are you nauseated or anything like that? All right. Sometimes there's a vagal type response that you get after a needle is put in your chest. So
All right, but you're done. So this is slowly going to improve that area, okay? And that's collapsed, and we're going to get a chest X-ray to compare in just a little bit. All right? Okay. So the next step is to get a confirmatory X-ray and then to repeat another X-ray in about 30 minutes time.
all right.
Okay, and then we continue to watch the patient for any complications.
Okay.
All right, we're just a chill. And you can actually see the fluttering of the little flutter valve here that will indicate that you're essentially in the thoracic cavity.
What's this thing called?
Urocell?
Is it Y? I mean, UROCELE?
You're
good.
He did well.
Okay.
Did you step out of the room?
I did.
Okay. That was for your own
It was from
peace
my
of mind.
own, yes.
Yeah.
If you're still hurting, we can give you some more medicine. You okay? You sure? Promise you'll tell me if you start hurting? No nausea? You don't feel like you're gonna throw up or
Yeah,
anything,
Patrick,
right?
you don't have to be tough and all that. I mean, just we
You've already
understand.
been tough. Doing this was tough.
Yeah, you don't have to be tougher. Okay, so you just asked how we know when it's back to normal size, and we're just going to go ahead and repeat the X-ray right now, and then we'll follow it with X-rays. Dr. Mean, how often do you want to do X-rays on him?
A repeat X-ray should be performed in about 30 minutes time to see that we've got some resolution of the pneumothorax.
Okay, good enough. Now, are we going to put him in our observation unit? Do you guys, family medicine, going to concede to that? Or?
That's the plan, yeah.
Okay.
Kind of just watch him and see
All right.
how he does as far as the resolution of his pneumothorax.
Okay, all right. I mean, if you guys want to admit him upstairs to your to the
I
surface?
think him going off is essentially a bed issue. If we can get a bed upstairs, then he'll come upstairs.
Okay, all right, sounds good.
Perfect. Lift your head
So it's
back.
x-ray time.
Does this stay on there? Yes, it does.
Yeah, that stays on. Don't take that off.
You sure you don't want me to rip it out?
I think you would have a couple people unhappy with you.
Probably.
You know you're gonna be on YouTube, you know?
Oh, man. Caught me off guard.
Okay.
Patrick, taking a big deep breath for me?
Absolutely, and your
Blow it
family.
out.
See, I'm worried
All
about
the way
my
out.
thyroid.
Taking another deep breath and
Too
hold
old to
it.
worry about the rest.
Hold it. You can breathe.
So Patrick, on a scale of 10, how bad was the pain when that went in? 10? Okay. And how long did it last as a 10?
Right after he got done, it went away.
I'm coming.
Went away. Okay, so it was just it was less than 30 seconds that you had the severe pain.
Yeah, well,
Okay.
Especially if there's increase in lung markers. They're saying there's increase in lung markers here as compared to here.